Okay, good afternoon or morning, depending on where you are, everyone. Welcome to today's all-member national MCH policy call / COVID town hall. I can't believe it's December already. We have a great agenda, I think, lined up for you today. But first, just a reminder of housekeeping rules. Most importantly, if you have any technical difficulties, please contact Jess Cohen, jcohen@amchip.org. And if you are typing into the chat, we ask that you try to make sure to click on all attendees so that everyone can see your question. So I have a bit of a legislative update today, then I'll turn it over to Dr. Warren for an update from MCHB. We're pleased to be joined by guests from Colorado's Medicaid program to talk about specifically their behavioral needs response to COVID-19. And then we will have Dr. Reefhouse from CDC sharing some updates from their agency. So on the legislative front, as we've been talking about, the current continuing resolution, which has kept the government funded at FY20 levels from September 30th through now, expires in just a little over 1 week. So that's December 11th is the deadline. To remind you, the Title V program within the different appropriations bills we've seen, FY20, the final number was $687.7 million. The House did complete work on their FY21 appropriations bills and included a really nice increase to $718.2 million. And a recently released draft from the Senate committee included $707.7 million, although that was only released by the Republican side of the committee and was more of a negotiations point. So those negotiations continue, and they really need to come to an agreement before the 11th, right? So they have time to vote in both the House and Senate. There have been some sticking point issues. I switched the order, sorry. So one is around veterans medical care and the other is around border security. So neither of those really fall into the labor, health and human services bucket that we tend to pay the most attention to, but because there's not time to pass all of these bills individually, they're not going to put them out until they have an agreement on all of the appropriations bills. So hopefully, they're working really hard on negotiating those sticking points so that we can see a bill passed by next week. But I'm guessing that it will, as always, come at the last minute. We might not see text until just a few hours before they vote on it. Also on the, Olivia, can you help me go backwards? Oh, there we go. Also on the appropriations front, we are really, I was really excited to see it's appropriations and other committees. On the House of Representatives, they've started picking their leadership for the various committees. And so on the Energy and Commerce side, the Republicans picked Kathy McMorris Rodgers to be their lead Republican on that committee, the ranking member, which is really significant. She's, first of all, going to be the first woman to hold a top position from either party on this committee, but also in terms of her allyship over the years for maternal and child health issues. So first of all, she is the mother of a son with special health care needs and has been an advocate for children with special health care needs, especially Down syndrome, like her son. And also she was the lead on some of the maternal health legislation that's been moving through the committee recently as well. Also played a part in negotiating the Medicaid postpartum extension legislation. So we were really excited to see that she's going to be taking this post because I think that gives us a great advocate on that side of the aisle. And then on the appropriations side, Rosa DeLauro, a Democrat from Connecticut, is going to be the new chairperson. She's from the Democratic side. She's actually pictured here with the current chair, Anita Lowy from New York, who retired and didn't run for re-election this year. And Rosa DeLauro was, until now, the Subcommittee on Labor, Health, and Human Services chair. So she has, like super, super intimate knowledge of all the programs that we care about in labor, health, and human services, but is also a tireless champion for maternal and child health issues throughout her career. And so I think having these placed leaders on these committees are going to be really important for advancing our priorities in the next Congress. And I wanted to be sure to point that out. On the COVID relief side, I have a couple of clips from different news stories that I've read over the past 3 days as breaking news alerts. So first, what we saw was that a bipartisan group of senators in the Senate, obviously they're senators, have released a framework for what they believe could be a COVID relief plan that is much lower than in total cost than what the House has passed. As you may recall, the House has passed a few versions now since May that have not been taken up by the Senate of COVID relief. And so, Senators Manchin and Collins were two of the leaders of this group. And they didn't release a bill with text that has, exact amount of funding for different programs. They released this framework showing the top level numbers and where they want to invest in terms of categories, really. So there is, in this framework that they released, $160 billion for state, local, and tribal governments, which has been a big sticking point until now because there's been disagreement. Mostly the Democratic side has been the one that has been trying to push greater relief for states and locals and tribal governments. The Republican side has been pushing back against that. So this was included in the bipartisan framework. So that was positive. But we know that this bill is less than $1 trillion. There have been House bills previously that were, $2 to $3 trillion. So that doesn't leave as much extra support for specific health programs like Title V or other programs that we've supported. Again, we wouldn't know exactly what's in this bill since it hasn't really been written. It's been more used as a framework for negotiations. But it's out there, and there's been a lot of resistance earlier on to passing a sort of scaled down version of COVID relief compared to those larger bills passed by the House. Excuse me. But now there's also been a lot more pressure within the Democratic Party to say, how can we possibly go home for Christmas without doing anything? Initially, the reports were that Leader McConnell in the Senate shot down the bipartisan plan, and he said, it's a non-starter. It includes too many things that I don't want to support. But then by yesterday, there was signs of life for the bill when Pelosi and Schumer both said that they would be using this framework for negotiations after previously not supporting bills that had been this small in their total expenditure. So getting conflicting stories, different sides of the aisle, different parties as usual. The good thing is it means they're talking again. They hadn't been for a while. They've been, in fact, I think we talked about this on the last call, that they couldn't even agree whether they were talking about it at all or if they were just talking about appropriations. So it seems like there are more serious conversations going on, but there are still a long list of concerns from both sides about what is or isn't included in this framework. This is the best we have right now, so we will continue to update you if there's any progress. And then finally, I just want to give you all a heads up that some legislation that we've discussed previously related mostly to maternal health that have passed the House of Representatives but haven't been considered yet by the Senate are still in consideration. But if Congress doesn't act on that in the next, week, 2 weeks or so, we'll lose that opportunity in this Congress. So AMCHP has been working with partners to raise awareness about these bills. So just so you know, there is some legislative action alerts out there on this as well. You might have seen them come through other sources or listservs that you're on, but we do hear from the Hill that there is still a chance for passing both the Maternal Health Quality Improvement Act, which has a number of public health programs related to reducing and eliminating preventable maternal death, as well as the Helping Moms Act, which would allow states the option of extending Medicaid to 1 year postpartum for all women, regardless of their pathway to Medicaid or CHIP. We will keep you posted. We're hopeful there could be movement on that, but it's still a work in progress. So with that, I will turn it over to Dr. Warren. Thank you.
Thank you so much, Amy. Good afternoon or good morning to folks, depending on where you are. I wanted to share first a brief update on some items that are rolling out today across the department. So if we can advance to the next slide, this one, yep. There are two key documents that have been released today from HHS. The first is the Action Plan to Improve Maternal Health in America, and the second is the Surgeon General's Call to Action to Improve Maternal Health. The first one that I mentioned, the Action Plan to Improve Maternal Health in America, outlines some key goals and targets, and we'll talk about those in just a moment, and then summarizes the work that's happening across the department to ensure that our country is one of the safest countries in the world in which to give birth. And I said across the department, I'm certainly sharing from the perspective of HRSA, Maternal and Child Health Bureau, but this action plan contains a listing of programs and activities from various operating and staff divisions across the department. So this is not a HRSA MCHB document, it is HHS-wide. The Surgeon General's Call to Action outlines some very concrete strategies that folks can do at a variety of levels, and we'll dive into that in just a moment. Next slide, please. So the vision that's represented across these documents is ensuring that the United States is one of the safest countries in the world for women to give birth. Next slide. And the action plan outlines some very key targets for improvement that we want to focus on. The first is reducing the maternal mortality rate by 50%, so cutting it in half in 5 years. The second is reducing the low-risk cesarean delivery rate by 25% in 5 years. And the third is achieving blood pressure control in 80% of women of reproductive age who have hypertension over 5 years. So you will see reflected in those targets measures that you all are already thinking about in terms of Title V performance and outcome measures, and you'll see a recognition of the life course perspective and thinking about health across the life course, not just during labor and delivery and pregnancy. Next slide, please. So with those key targets in mind, there are 4 goals that are outlined in the action plan. And again, here you'll see a life course perspective, which we're really excited about. The first is achieving healthy outcomes for all women of reproductive age by improving prevention and treatment. The second is achieving healthy pregnancies and births by prioritizing quality improvement. And the third is achieving healthy futures by optimizing postpartum health. There's also a 4th goal related to improving data and bolstering research, recognizing that additional research to fill in some gaps, but also really robust data sets are absolutely key to us moving forward and making progress. So again, excited for folks to see this life course perspective represented across these various goals. So all of these are in the action plan. I'm going to share the links with you in just a moment, but encourage you to look at them, see where there are opportunities to amplify those with the programs that you are implementing in your states and jurisdictions, and how you all can weigh in to help us accomplish the targets that were listed. Next slide, please. So the Surgeon General's Call to Action contains some summary information about the state of maternal health in our country, a call out around disparities and identifying those, and then really enumerates what different sectors can do. So there are specific sections for women and families, states, tribes, and local communities, healthcare professionals, health systems, hospitals and birthing facilities, payers, employers, innovators, and researchers. So the intent is that anybody picking up this document will say, what can I do? And they will see their perspective. They will see themselves reflected in this document and see very concrete steps that they can take to help improve women's health. Next slide, please. A few key messages that are in the call to action that I think are important to share. Again, this life course perspective, recognizing that We have to think about women's health across the life course, including in young girls and adolescent females, if we're truly going to think about changing the trajectory of maternal health outcomes in this country. There is also a recognition of the importance of access, quality, and safety with regards to clinical care, and so thinking about hospitals, birthing centers, and other clinical settings. There is a strong recognition that we not only need to understand but address the contributors to disparities if we're going to improve maternal health and reduce both maternal mortality and severe maternal morbidity. And finally, a key message is that this is really going to take a multi-pronged approach. No one set of stakeholders, no one sector owns this problem alone. This really is going to require concerted effort over time from all of us to be able to make considerable progress. Next slide, please. So what are the things that you can do? As I mentioned, think about your contributions to the effort. Many of the programs that you receive funding from us for already are working to address improvements in maternal health, and many of them, in fact, are cited in the HHS action plan. So the block grant, home visiting, Healthy Start, and AIM are all there. And so I would encourage you to continue to think about not only what you're already doing, but what else you might be able to do to support this effort. For those of you who are on social media, please feel free to amplify the messages that are coming out of the department today. So you see the Twitter, Facebook, and Instagram handles there, where you can follow HHS and the various operating divisions media, but also help amplify the messages specifically about this rollout. And then think about how you can engage your state and local stakeholders around the action steps that are identified. One of the most important roles in my mind of Title V from a leadership standpoint is your convening role. You are trusted authorities on the health and well-being of mothers, children, and families. You've got trusted relationships with stakeholders at the local and state level. And so we would encourage you to use these documents to help amplify your efforts and to support your work and make the case for why this work is so important and that you need to continue it. Next slide, please. And these were shared with you, so you'll have these links, but these links just carry you to the documents so that you'll have access to them and you can see them for yourselves. There's also going to be a stakeholder call at 3 p.m. that is open broadly. We'll actually try to get the registration link for that and paste that into the chat window here. If you've not already registered, you can still do that. And so we will share that in the chat window momentarily. Next slide. So separately from this, wanted to share with you all a request for information that has been put out by the HHS Assistant Secretary for Health. The OASH is seeking effective and innovative approaches and best practices in responding to COVID-19. So a really broad call where they're wanting to know what are the bright spots, what's working well, what have you been able to do in communities and states to be able to respond to COVID-19. And so the link here, and again, these are available in the slides that you were sent, has a link to the response portal, so you can go and find out more details about this information request and also submit your response. And those responses are due in about 3 weeks from now, the 24th. Next slide, please. And thank you, Amy, for posting the registration link to that stakeholder call. Again, that's at 3 p.m. Eastern time, so in about 40 more minutes. So thank you for that opportunity to share an update. If you've got questions, please let me know, share those in the chat, and I'm happy to respond. I want to turn now to Melissa Edelman, who's from Colorado, from the Department of Healthcare Financing and Policy, who is going to talk to us about the way that Colorado's Medicaid behavioral health initiatives have been stood up in response to the COVID-19 public health emergency. So I'll turn it over to Melissa.
Good afternoon. My name is Melissa Edelman. I work for the Department of Healthcare Policy and Financing. I apologize, I can't seem to make my camera work today, so I apologize for that in advance. Is it possible to go ahead and advance to the next slide? Thank you. So I was asked to come in today and speak to you specifically about some of the responses that Colorado has had for the public health emergency around COVID, specifically in the area of behavioral health. And so I thought it might be helpful to first kind of get a base understanding of how things work in Colorado. So our approach in the state makes a little bit more sense. So for the past 20 years, we have functioned under a unique structure where our behavioral health services are administered underneath a capitated behavioral health benefit. It used to previously be run by behavioral health organizations. As of 2018, we actually re-procured, and we have a structure where our capitated behavioral health benefit is run by regional accountable entities that also are responsible for administering the physical health portion of care coordination, but the physical health services are still billed fee for service. So really the capitation applies only to the behavioral health piece. And so again, we've had this program for about 20 years, and it functions under the authority of a 1915B3 waiver. And that waiver specifically gives us the opportunity to have managed care. But in addition to that, it allows us to cover services that we would not be able to cover otherwise under fee for service, as long as we can continue to demonstrate that it's cost effective. So these are the 7 regions of the state that are responsible for our capitated behavioral health benefit. Next slide, please. So in response to the public health emergency, while Colorado did participate in some efforts for 1135s and 1115 waiver asks, most of those asks were around our general Medicaid needs or around our long-term care populations, and not specific to behavioral health. And the reason of that is because we did have that 1915B3 structure in place that allowed us flexibilities that we didn't have to really change much within the program, except from a kind of contracting and operational perspective with our RAIs, our managed care organizations, to put in some things very quickly to respond to COVID. And so the things that we really focused in on were the utilization of telemedicine and alternative funding strategies. Next slide, please. Okay, well, I guess you can go back. So through the telemedicine services, what we did, we have the ability, again, under the 1915B3 to have additional flexibilities for our services that are not offered underneath of our state plan. And so this gave us the opportunity to work with our RAIs to really open up telemedicine so that any service that made sense for them in an outpatient setting, and that includes most outpatient treatment services, can be delivered via audiovisual, telephone, or live chat modalities when it's clinically viable and appropriate. And so the RAIs maintain their ability to prior authorize services, to contract with specific providers, to do lots of services. This was important for us to figure out really early on. A lot of our behavioral health program, because of the way that we function, when we say community behavioral health program, it's really because there's an emphasis of keeping members served in the communities. We really don't want folks in inpatient or residential settings. And that's kind of been the perspective of the program for the past 20 years. So we rely on alternative services, is what we call them, B3 services, such as like Clubhouse, drop-in centers, peer support services, some of those lower cost but really effective services for members that provide them a sense of universality and community. And in a time like COVID, our folks that have been maintaining well through the use of these services, that was a hard hit for them. So they lost their ability to have some of that peer and social interaction with folks. So we wanted to work with our RAIs to really create an opportunity where we could continue some of that that type of servicing online, and not just requiring everyone to rely on psychotherapy services, for instance. And they've gotten really creative and trying to bring some of those clubhouse services and psychosocial rehab services into a telehealth setting. Some folks don't have computer access, so we've seen a lot of kind of phone call, video touch-ins with folks when possible through like smartphones. We've had some of our community mental health centers have been able to set up like successful kind of like day treatment programs with some of their members so that they can attend in kind of group settings too. So we've seen a lot of innovation to really reach out and meet the needs of the high-risk members. And so, of course, as we were employing this strategy in the beginning, the effort was really around identifying those folks that we knew the COVID situation was going to have a big impact on, and developing safety plans and risk mitigating strategies to work with them effectively. And is it okay if I ask anyone if they have questions at this point before I move forward?
Absolutely.
So, okay, that was just the telemedicine piece. The other piece of alternative funding strategies that we find really cool underneath a managed care arrangement. And again, specifically in Colorado, community mental health centers remain a cornerstone to our state's behavioral health system. We've encouraged our RAIs to use alternative funding strategies that are available underneath the capitation to support those community mental health centers in creatively meeting members' needs. And so some of the things that we saw where folks were coming in and they were having medications administered, or they were participating in peer support services, those kinds of things. We actually had clinicians going out to homes or in the beginning, dropping off medications, working on kind of food service programs for folks that didn't have access to that. Just really trying to stay in touch with their members, and in some instances, really just keeping their base needs kind of intact as they worked creatively through their RAI structures to do that. And so one of the examples that we can talk about with the community mental health centers is that we encourage the use of subcapitation arrangements. So it's kind of less of what we think of as a fee-for-service model where you provide a service and we pay you for it. What they're doing instead is they're providing a subcapitation to these community mental health centers, and they're saying, of our members that you serve, provide what services they need, and then we'll work with you on basically the payment structure of that. So it's not provide a service, get paid, it's serve our members' needs, and it allows for a little bit of additional flexibility in some of the services that they could provide, which wouldn't be traditional billable services. And so during that allows the department to not require subcapitation payments to be reconciled to the RAIs. So they don't have to show us that fee for service piece where you paid for a service and they're demonstrating that to us, that they're really paying for the overall care of a member. And we were also able to work with the RAIs as far as our rate setting methodologies in the future, understanding that there will be an anomalous period during the state emergency months or the federal emergency, and that we'll work with them to consider that in kind of future rate settings. So with an understanding that there's going to be kind of a change in some of the traditional patterns of utilization, which we use patterns of utilization to set rates, that we will take all of that into consideration when we think about setting their future rates, so that it continues to emphasize and work with them, trying to work with their members to meet their current member needs. Okay, any questions, folks?
And of course, you can type questions into the chat box or ask them later on as well. But maybe I'll go ahead and move to Dr. Reefhouse for her presentation on behalf of the CDC. And again, if anyone has questions for any of our presenters, feel free to chime in on the chat box at any time.
Thank you so much, Amy. Good afternoon, everybody, or good morning. My name is Jenita Reefhuis, and I am, my real job is being the branch chief for the Birth Effects Monitoring and Research branch, but in my capacity as acting division director for the Division for Birth Effects and Infant Disorders, I have the honor of representing Dr. Karen Rimley, who is currently working on the COVID response, but who is our new director for the National Center Center on Birth Defects and Developmental Disabilities. I am here to give you an update on things related to maternal and child health from CDC's COVID response. But before I get started with COVID, I do want to again remind you to please go get those flu shots and tell all your friends and family too. If you didn't tell them during Thanksgiving, please tell them on your Zoom call with your family during any other holidays that you may celebrate. So from the response, a first important update that I think many of you have seen is the recommendations around vaccines. So before one or more COVID-19 vaccine is authorized for use by FDA, a committee of medical and public health experts that advises CDC, they have met to provide interim guidance on who should get the initial doses of the vaccine. And so on Tuesday, the committee recommended healthcare personnel and people who live in long-term healthcare facilities that they should be the first to receive the COVID-19 vaccinations while the supplies are limited. The committee intends to meet again. I mean, they really meet quite regularly following any authorization by the FDA for vaccine-specific recommendations. And then kind of specific to maternal and child health, obviously we know that among the healthcare personnel, there are going to be women that may be pregnant. And so that's definitely, I know, on the minds of my colleagues who are working on this. And so we're really hoping to be able to share more around that coming up. Then also, CDC has released new guidelines around quarantine after exposure. And thank you, Sasha. I think Sasha is putting in the links where you can find more information about what I'm sharing with you. So thanks for that. CDC is providing public health agencies with options to shorten the length of quarantine in some situations. So under these options, your local health department may decide quarantine can end either after 10 days without a COVID-19 test, and if the person has reported no symptoms during the 10-day period, or after 7 days with a negative test results, and if the person has reported no symptoms during that period. But still, the best way to protect yourself and others is to stay home for 14 days if you think you've been exposed to somebody who has COVID-19. So check your local health department's website for information about options in your area to possibly shorten the quarantine period. But overall, it is really important to remember that quarantine helps prevent spread of disease that can occur before a person knows that they have the virus, or if they just have no symptoms at all. We are working feverishly on other guidelines. So the winter holiday guidelines are coming out soon, hopefully by the end of this week, but otherwise early next week. And there's also new tools coming for educators and schools around K-12 schools. So guides on how to set up a classroom, guides on how to plan for teacher and staff presence, and things for and updates to the frequently asked questions for administrators, teachers, and parents. I think we're all very involved in how to get our children educated in a safe environment for both our children, but also their teachers and other staff working in schools. So I think that was really my main things to share. Keep an eye on MMWRs coming out. I think you guys have hopefully seen the implementation of hospital practices that are supportive of breastfeeding in the context of COVID-19. So that's really important information, and just keep an eye on those as they come out. So with that, thanks again for your time. I look forward to continue to give you updates on the important work that CDC is doing around COVID.
Well, I think Dr. Rifas has frozen a little bit, but also was ending her presentation. So hopefully that timing wasn't too disruptive to her presentation. Thank you if you can hear us for everything. Lots going on, of course. I'm also really interested to know how states and especially the local health departments are going to be making determinations on adopting the new quarantine guidelines, because those, of course, also really impact procedures, you know, whether at like schools that are open or other settings where staff are going in person and employees are going in person. So that was really interesting to me. So I will leave some time now if there's any Q&A, and feel free to keep typing in the chat, or if you want to raise your hand or unmute yourself and turn on your video and ask your question. But I will also share some other updates in the meantime. As you recall, it is now ACA open enrollment season for another 2 weeks. There's actually starting to be a push for the new administration to possibly extend it when they take office, but that's just, I think, a rumor at this point. And so please feel free to check out AMCHP's resources for state Title V MCH programs on ACA open enrollment season this year. And a special shout out to my colleagues on AMCHP's Health Systems Transformation team for putting that together. The AMCHP conference call for proposals are now open. So we hope you will submit an abstract and join us, whether we're in person or virtually or some combination of the two. And there's a link for you here on that as well. So I'll leave this up. You know, you have our next call in 2 weeks, the 17th. That will be our final call of the year, and hopefully we'll have plenty of updates for you by then regarding the status of appropriations and possibly even COVID relief. There is a question. Thank you, Allison. This is something we've been discussing at AMCHP, so we're going to ask our folks on the call. There was a recent MMWR from CDC the impact of COVID-19 on pregnancy, but then the NIH director also recently authored a blog post about a separate study, and the two studies almost sounded to be a little in contradiction with each other. And so I know Dr. Riefhaus seems to have fallen off, but I know we do have some other folks from CDC on the call, perhaps folks from HRSA or others on the call. Sasha, I know you're on. Are you still there? Or Sarah Foster, are either of you able to address that by any chance?
Hey, Amy, I'm here. Can you repeat the question?
Sure. And so there were sort of conflicting conclusions on, there was an MMWR using SETNet data on the impact of COVID-19 on pregnancy. And then recently the NIH director authored a blog post about a different study, and the CDC's MMWR kind of discussed findings of severe impacts on pregnant women, whereas the NIH director's blog was more optimistic on how most pregnant women are not severely impacted. So we were just wondering if you have any insight into that, or if you know of any ongoing work between NIH and CDC to do some of this research, or even co-author something together.
No, thanks for the great question. I do not have any details. It'd be wonderful. I don't know. It sounds like maybe Unita isn't able to hear anymore.
Yeah, I think she dropped off.
Yeah, so that's unfortunate because she's the good person to ask. But I'm very happy to take this question and follow up and get you an answer.
Great, thank you so much. Do we have any other questions from the audience? We're also happy to wrap up a little early today and let you all register for the HHS call at 3 o'clock Eastern time for more details, although I think we got a really good overview from Dr. Warren about the new efforts on addressing maternal health. And thank you, Dr. Carlos, for sharing the link to the NIH blog, which I think only went to the panelists, so I'm going to send it to everybody in case you were interested in this as well. But we were having conversation at AMCHP about some different messages coming out, and so much of the work that you as our members do to inform the public is really contingent upon having the right information and messaging. And it looks like Dr. Reefhouse is back, so I'm not sure if you heard the question earlier.
I didn't. Sorry. No. Sorry. I'm so sorry I dropped off. Or we've been having some connectivity issues. So what was the question?
No problem. And I'll apologize to everyone in the call if you hear me say it the third time, but there was a recent MMWR from CDC that seemed to suggest some more negative impacts of COVID-19 on pregnancy, but then there was also an NIH director's blog that was more optimistic about most pregnant women not being severely impacted. So we were just wondering if you know how to reconcile the two, or if there's any work ongoing between NIH and CDC together to co-author something, kind of share a message that helps us understand the differences. I mean, these two studies may also have been looking at different populations.
I think they were looking at different populations. There's a lot of ongoing work around pregnancy, and you know, one of the challenging things is that there's a lot of data available now, and so you know, you have to make sure that then kind of the messages jive as you do analyses looking in different data sets. And, you know, it's really important to know what the source population of your data is and how that could impact the findings that you have. So if you start off with a population of hospitalized women, you're going to have very different pregnant women than if you include women from a population-based study where you're including pregnant women regardless of whether they were hospitalized or not. So so yes, it's definitely, we have a large team of people that are really focused on looking at the interconnection between pregnant women, infants, and really doing that linked surveillance well. So stay tuned, there's definitely more coming out. And as far as kind of discussing it with other groups outside that are also doing analyses, I know that we are talking with several of the universities that are having big studies and that are conducting larger cohort studies, for instance. So we're trying to stay connected with everybody who is doing work around pregnant women and COVID.
That's great. Thank you so much. And I know we'll be looking forward, and we know we can count on CDC to share the latest. I know that another topic of interest, of course, is going to be around vaccinations and pregnant women and vaccinations in children. So be on the lookout, because I'm sure that will be a topic, if maybe not in our call in 2 weeks, but certainly in the new year. So many questions around both of those and how those studies are going underway.
Yeah, no, absolutely. And it's something that that we are working on and preparing for, not only on how to roll it out, but also then how to track how those pregnancies develop. And as you know, also, you know, we don't know a whole lot yet about, for instance, birth defects and COVID, because not that many pregnancies have been completed when they were exposed in the first trimester. And so that's also going to be the case for vaccinations, where to have that complete picture, you need to be patient when it comes to pregnancy, because it's going to take 9 months. So that's something that we are preparing for and working towards.
Great. Well, thank you so much. One last call for questions from our audience today before we let you go. And again, if you want to register and jump on the HHS call, that's starting in about 15 minutes or so. Otherwise, we will hopefully see you in 2 weeks. And thank you so much for taking time to complete the quick survey at the end of the call as well. Have a great rest of your day.